Hello, everyone, and welcome to tonight's webinar. My name is Dr. Jay Burton, and this evening we're going to be discussing early treatment as it relates to the orthodontic patient and when to refer. Here you can see my lovely family, my wife Sarah, my oldest daughter Nora, my son Baker, and then youngest daughter Charlotte. So a little bit about me and kind of what's going on in my life and what led me to end up here giving a webinar on early treatment. One, I'm a board certified orthodontist by the ABO. I'm a key opinion leader for Plan Mecca, who I want to thank for sponsoring tonight's webinar. Also on the advisory board for both OrthoScience and Form Labs. In my previous life, I was an assistant professor of management and marketing. Then I met an orthodontist who convinced me to go to dental school. So I went to dental school at the University of Louisville and then did residency at NYU and then been practicing here in Nashville, Tennessee with 2 locations. One just about to open. Been working out of a general dentist's office for about the last year and a half. A good friend of mine, Tom Hadley. And then with the plans of opening my own office there that is scheduled to finish up right as we're ready to finish up quarantine. So, and then my other location, my main office is in Hendersonville, Tennessee, which is a suburb just outside of Nashville. So what are we going to talk about this evening is early treatment and orthodontics and what types of cases will benefit from early treatment. And so we're going to look at some transverse problems and learn to identify those, discuss anterior cross bites, open bites, how habits can affect malocclusion, and then we'll look at ectopic eruption of molars and canines and how that affects our dental development. We'll discuss class 2 and class 3 cases, look at the premature loss of deciduous teeth and how that can negatively impact an orthodontic case, particularly the eruption of permanent teeth, and then discuss moderate to severe crowding cases, spacing cases, look at deep overbite, and then severe overjet, and then also discuss dental trauma. And we'll try to throw in a couple of cases towards the end that will kind of let you see some ill effects that could occur if patients aren't referred in the correct time frame. So when to refer, that's a question that I often am asked, and the American Association of Orthodontists recommends that children see an orthodontist at age 7. As soon as I say that, usually I have, depending on who I'm talking to, whether it's a parent, a hygienist, an assistant, a dentist, usually it's like, oh, why so early? Isn't that so early? Are you going to treat my 7-year-old child? Chances are no. The reason that we want to get them in early is so that we can monitor the exfoliation and eruption of teeth, so we can monitor their growth and development, and then look at the occlusal and skeletal relationships that are developing. So no, it's not our ego where we just want more patients and want to see more patients. It is really we're wanting to monitor that growth and development for you to take that off of your plate because y'all have enough to worry about as it is. So anything that we can do to help facilitate this for y'all is beneficial. So what is normal in a 7-year-old? And for those of you with children, my daughter is 6 years old and we've got a couple neighbors that are 7, and there's not much normal about a 7-year-old, honestly. They are just weird kids. Their teeth are weird. Their teeth do weird things. The baby teeth aren't falling out like they should. The permanent teeth aren't coming in like they should. It's just a hot mess a lot of times. And particularly when they show up in my office, generally speaking, they're a real hot mess. So I like to see them early. I wish I got more 7-year-olds in the practice so I could follow them and intercede at the appropriate time. But sometimes either the dentist refers or the pediatric dentist refers or hygienist refers or assistant refers. and the patient just doesn't take it seriously because of the attitude that, oh, these are just baby teeth, what does it matter? But when it comes to the growth and development of their child, it really does matter, and that's where we really need your help in explaining the significance and importance of monitoring the patient's growth and development. And really what we're looking at is the transition of from the primary teeth to the permanent teeth over time, and seeing how that relates to jaw growth, seeing how that relates to environmental factors, and just what's going on with that individual patient's life. So here I've looked for this diagram. I remembered it from dental school back in the day, and Schauer and Masler's dental development chart, which I always thought gave a really good representation of kind of where things should be at a specific age, plus or minus 9 months. And so I'll use this in the office quite a bit to compare the patient's anatomy with where they should be as a reference for mom or dad. And then here we go, 7 years old, 8 years old, 9 years old, and 10 years old. Most of the time, this is the age in which we're going to be dealing with early treatment. And when I say early treatment, I'm referring to, it's called many different things. It's called early treatment. It's called phase 1 therapy. It's called interceptive orthodontics. Some people talk about it as limited orthodontics, but in my practice, what it usually means is you're treating a younger child. It's usually very problem focused. The treatment duration is usually kept somewhere between 6 and 12 months. Occasionally it will go over a little bit, but usually we're trying to keep it within that 1 year range or less. And we're really trying to facilitate or intervene in a situation to make things up or to set the case up better for phase 2 or comprehensive treatment. So again, when to refer, the AAO says age 7. Why age 7? Because usually by that point, the posterior occlusion is established, the first molars have erupted. We're able to look both at the anterior-posterior relationship of the molars as well as the transverse occlusal relationship to determine if there is either a skeletal growth problem, either transverse or sagittally. And then we're also able to begin looking at functional shifts that could result or could end up resulting as a result of the patient's bite, which could occur from a number of reasons. Just the oral environment, it could be habit related, could just be that patient's development, it could be a dental issue associated with ectopic eruption of a tooth or premature loss of a primary, or even just the partial loss of the primary tooth where it's just kind of hanging on there, thereby displacing the permanent tooth. So any number of factors could lead to a functional shift. The other reason we want to see them early is because by that point, usually the incisors have begun to erupt. And the incisors kind of give us an idea of whether the case is going to be crowded, whether or not we're going to have issues with regard to an anterior crossbite. Lets us know kind of the vertical relationship, whether we're looking at a deep bite case or an open bite case. Also, if there is an open bite present, then we can begin thinking, okay, what's the etiology of this open bite? Is it skeletal? Is it dental? Is there a habit associated with it? As well as begin looking at facial asymmetries that we can pick up on because midlines may be off. Maybe they're off because of a functional shift or something else, but we can begin to consider basically where things are with the patient. So we've got the posterior dentition, the molars have erupted kind of as the foundation, and the incisors have erupted, showing us kind of the aesthetics of the case or where things are headed. And then radiographically, usually when I have a patient come in that's around 7, 8, 9, most of the time those patients are being referred by the general dentist or the pediatric dentist. And most of the time when they are referred, they'll have a 2D pan that I would usually try to get if possible. And then with that, we can look for missing teeth, impacted teeth, ectopic teeth, whether or not there's any supernumerary teeth, and are there any cysts or other radiographic pathology present. And when we think of radiographs, a little bit about me and my practice, I've had CBCT in my practice, I think now for about 4 years. And honestly, I couldn't imagine practicing without it. I did ran the numbers the other day to see, okay, how many 3D volumes have I taken and how many 2D images have I taken on the Planmeca Pro Max Mid that I have. And it was almost 4,000 CBCTs taken in 4 years. And then I think it was 34 pans that were taken. And I can guarantee you those 34 pans over the course of a 4-year time frame, they were taken on either family members, because that machine has an extraoral bite wing feature, which is really nice. But I use it for family members, assistants, friends, primarily checking for caries. So not that there's not a need for 2D, but in my practice, I primarily am imaging in 3D. And why am I imaging in 3D? And it really comes down, for me, in part to the radiation hygiene. It's now possible with ultra-low dose technology to image a patient with less radiation than a traditional 2D digital pan. And so this research came out of, or was published in the JADA in 2008 by Ludlow. And you'll see the average dose for a 2D pan and Ceph ends up being somewhere between 15 and 30 microsieverts. Usually a pan is around 25, and then the Ceph usually runs around 5 microsieverts for a total of about 30 microsieverts on most machines. Some will be a little bit lower, some will be a little bit higher. The older the machine, chances are the higher the dose. So 3D, what that allows is basically much less radiation, almost in half in some cases, or more than half in some cases. So for early treatment cases, I'll do initial records and final records, because most of the time I'm not doing bracket repositions or progress records in those cases. For comprehensive or phase 2 cases, most of the time they'll have initial, progress, and final records. But with the ultra low dose technology, I'm able to image at lower radiation than 2D. So that's one of the main reasons that I choose to use 3D in my office. The other reason is, which we'll get to that shortly. And the truth is, any radiology company can reduce radiation by simply lowering KVP and lowering MAs. What Planmeca and some others have been able to do is really work with the data from the CBCT images using algorithms to maintain the image quality while reducing the radiation dose that the patient receives. Because it's not enough just to lower radiation dose. You don't want to lose diagnostic quality. Otherwise, what's the purpose of the radiation dose? So I think that's one area where they really have been successful when it comes to ultra-low dose, is lowering the radiation dose while maintaining the diagnostic quality of the images. And this poster was put together by Ludlow, and both at UNC and University of Helsinki on radiation dose. And then an article in the centennial edition of the AJODL on the history of imaging and orthodontics, from broadbent to cone beam computed tomography. In this article, the author stated that the evolution of CBCT took a significant turn, that manufacturers with a combination of partial rotation, low settings, and pulse technology were able to create a CBCT scanner that takes a 3D image with less radiation to the patient than a panoramic radiograph. And this resulted in the ideal combination of more information with less radiation. So it's not only that I'm able to image my patients with less radiation, but I'm able to get more information. I'm not going to miss supernumerary teeth that are outside of the trough. I'm going to know exactly how long the teeth are because I'm not going to have issues with foreshortening or elongation for that matter. So it allows me to work with one-to-one data. And this is an article by Ma on advanced applications of CBCT, and this was in Seminars of Orthodontics. And he said that the benefit of the CBCT for the orthodontist was it gave us a 3D representation of the dental and craniofacial structures of the patient. Not only that, but it allows us to reformat that image so that we can visualize a structure or structures from different angles and perspectives. And then in doing so, we don't have any magnification errors or projection artifacts that occur in other types of radiography. We're able to look at true one-to-one superimpositions over time to see what effects our treatment plans and treatment mechanics have had. And then we're able to, with this data, not only use it for diagnostic purposes, but even at times for modeling or planning purposes, as well as manufacturing applications. And then we've already discussed the radiation exposure issue. So there's significant benefits to the use of CBCT in orthodontics. What's been amazing to me is that the vast majority of orthodontists have not adopted this technology to the degree that I really thought that they would have. Now, I think that's changing. I think that there's been much more research done and it's much more prevalent in the literature. And as a result of its prevalence, I think there's going to be widespread adoption in the next few years. So another kind of benefit of Plan Mecca's ProMax Mid is they have an algorithm that's called CALM. And the great thing about that is the number one reason for having to re-expose a patient to radiation is due to patient movement during image acquisition. And what the CALM algorithm does is it basically, using the algorithm, it removes the movement that occurred while the scan was being taken. Now, it's not going to make this image 100% clear or 100% perfect, particularly on a kid that's moving a whole lot, but it will make a CBCT that would have been otherwise unusable due to patient movement, at least diagnostic for orthodontic purposes. Now, you're not going to use it for endo. You're not going to use it for implant planning or implant placement or anything like that. But for orthodontic diagnostics on a child monitoring growth and development, it's certainly good enough to give us diagnostic information. So, and patient movement can be a significant problem, particularly in the population of patients that we're seeing, particularly as they're young. So times are changing. Given the higher radiation dose with 2D versus 3D, I no longer can justify the use of 2D, and I would say the routine use of ultra-low dose CBCT is not only viable but recommended at this point. At one point in time, 3D radiography or CBCT was under fire, and I would say in the future we're going to see 2D radiography come under fire for higher radiation doses with less information. So it only makes sense, as the article in AJ Odio pointed out, from a historic perspective and the amount of information that we're able to get at a lower radiation dose to add, that's certainly beneficial for our patients and for our ability to treatment plan cases. So what are the benefits of early treatment? Well, one of the biggest benefits is improve the patient's self-esteem. A lot of these kids are being made fun of at school. Kids can be very, very mean to one another. And anything that we can do to minimize any negative attention that they might receive is certainly worthwhile. Not only does it improve the patient's self-esteem, but also the parent's satisfaction usually. Many times it can decrease the need for extractions. Often we're able to resolve developing malocclusion, and at times the patient won't even need a phase 2 treatment or comprehensive treatment. Usually, particularly in transverse cases and vertical cases, the stability of the final result is generally improved. And then the overall treatment time, though it has increased, you actually see a decrease in treatment time in the permanent dentition. So during phase 2, which is usually when the kid's in middle school or high school, you're able to see a decrease in that total treatment time, which patients certainly appreciate. And then also decreased iatrogenic damage to the dentofacial complex because things just weren't being monitored and weren't being dealt with appropriately. And what are the benefits to the orthodontist? I mean, those are the benefits to the patient. The benefits to the orthodontist is it increases our treatment options. There's some treatment modalities that we can use when the patient's young that we simply can't use when the patient gets older. We're able to take advantage of the growth potential, and most of the time, not always, but most of the time, we're able to have better patient compliance when we deal with early treatment cases than we would in, basically middle school or early high school patients. So what problems are most important to refer? And I would say these relate to skeletal problems, habits, so thumb and finger sucking, tongue thrust, mouth breathing, lip biting, things like that can cause some pretty significant skeletal changes to occur. Any type of trauma, if it's intrauterine, it's usually being dealt with in hospital-based programs or by oral surgery department. And then condylar fractures as well, dental and alveolar trauma. Many times these patients will need to be splinted or have arch wires placed to line things back up, because it's very likely that, particularly if the tooth is avulsed or had significant trauma to it, many times once things heal, you'll actually have ankylosis. So the necessity to treat very quickly and diligently in those cases becomes paramount. Skeletal growth patterns, looking at class 2 and class 3. So anytime you have a kid come in that's either severely retrognathic or severely prognathic, or maybe just mid-face deficient, it's ideal to get them to us as quickly as possible, because that's when we're going to have the most influence over their dentofacial growth. And then other growth patterns usually related to genetics is cleft lip and palate, hemifacial microsomia, all of the syndromic types of cases, and then also including rheumatoid arthritis. So, what is not normal? Well, a class 2 dental and skeletal relationship is not normal. I mean, look at the proclination on those incisors. And I'll also point out that this is a rendered Ceph. So it's a 2D rendered image from a 3D CBCT volume. And with that, I'm able to reorient the head. So if the patient wasn't positioned correctly in the machine, I can change that based upon natural head position and orient it any way that I would like to orient it before creating the Ceph. And then, so anything that's class 2 in nature, where you've got a recessive mandible or prognathic maxilla, get those patients in to see us pretty quickly. The reason being is we have quite a bit of control over maxillary growth with the ability to both inhibit the maxillary growth as well as redirect maxillary growth at times. We can move the maxilla distally. We can, to some degree, though limited in nature, we can stimulate mandibular growth. Most of that is actually coming from dentoalveolar changes and not so much condylar growth. If you see a case where they've done a functional appliance or something to quote unquote grow a condyle, chances are that patient was going to grow anyway. But anything that we can do to improve the situation is certainly beneficial. And then the ability to translate maxillary posteriors distally, dealing with distalizing appliances. In my office, most of the time I'm doing this with TADs or some sort of TAD supported appliance. And then once the patient's growth is pretty much ceased, or we are unable to take advantage of it, then about the only option available to the patients, and this is where many times it can be quite sad. Had we seen the patient earlier, we could have often avoided orthodontic surgery in some cases. But if they're referred too late, then many times that's about the only option on the table. So very important to, again, see these kids pretty early. In class 3 cases where you've got an anterior crossbite or retrusive maxilla or prognathic mandible, get those patients in to see us. Chances are we're going to be looking at doing protraction face mask. And the most successful time to do that is usually between the ages of 7 and 9 years old. So again, that maxilla is really malleable, and the sutures really allow them to be developed as they are young. But as they grow, then those sutures begin to fuse. Our ability to manipulate that maxillary growth really becomes limited. So when we're talking about anterior crossbites, you'll see here, this is a case where I placed mini plates on. It was an older patient, not an adult, but just an older kid, probably 11 at the time. And I thought, okay, I'm not going to get very far with traditional face mask. There have been some reports in the literature using mini plates and some class 3 elastics. So this is one of those cases. Unfortunately, this patient actually moved away on me, so I didn't get to finish his case. But this is just an example of other options that we have to employ when we don't see the patient soon enough that we can begin treatment with the face mask. And sometimes it just needs individual tooth movement with fixed or removable appliances. But if it's truly skeletal in nature, then either we're looking at orthopedic correction, or if it's too late for that, usually some kind of surgery being involved. And regarding crossbites, here we've got posterior crossbites, and we've got a dental anterior crossbite as well. And usually what we're looking at when it comes to posterior crossbites is to distinguish what type of crossbite it may be. And one thing that helps us do that is the coordination of the midlines and how the mandible is closing. If we're evaluating that and the patient is shifting over upon going into CO, then we're able to say with pretty good certainty that's a functional shift that's occurring. And if we can expand the maxilla, then chances are we'll be able to achieve a more coincident midline and potentially avoid any asymmetric condylar growth that would occur. So the other benefit of early treatment is we're able to harmonize the width of the arches, particularly if we can get a hold of them early. And University of Pennsylvania has actually done some research on this, showing that multiple rounds of phase 1 with the expansion and lip bumpers or similar appliances, in a significant portion of the cases, they did not even need a second phase of treatment. So there's some benefit to expansion early on. I think more research needs to be done on this topic to determine what kind of cases actually benefit from this therapy the most. But when it comes to expansion, there's a nice little chart. I think this came from Prophet's text for a differential diagnosis, whether it's a dental issue, a functional issue, or a skeletal issue. And if it's a skeletal issue, many times you'll see that CR and CO are actually coincident. Usually there's smooth closure. A lot of times the crossbite is present on both sides posteriorly, and then it's the entire posterior segment, not just one or two teeth. If it's one or two teeth, then chances are it's a dental issue. If it's the posterior segment, but CR and CO are different, and you see that lateral shift upon closing, then you're looking more at a functional issue. And then with regard to treatment, if it's dental, you're really focusing on dental movement, tooth tipping. If it's functional and there's some interferences present, then you might need to do some bilateral expansion. And then for skeletal problems, you're going to want to make sure that that you have more palatal expansion take place. And in older patients, we've found that the mid-palatal suture can be very difficult to open up, even with TADs and mini plates being placed and skeletally fixated appliances, and with an effort to expand that mid-palatal suture can be very problematic and not have great prediction of success. So it's hard for me to recommend treatment sometimes when I don't have a good idea that it's going to work. And so again, the earlier we can intercede in these cases, the better off many times the patients are. So rarely are crossbites self-correcting, and because of that, usually the sooner we can correct things, the better off the patient is. Usually they become worse with time instead of better. Oftentimes delaying treatment can jeopardize a favorable outcome later. And then there's the potential for adverse condylar growth with waiting. And then anterior crossbites many times will result in trauma of the incisors, which I know we've all seen. So here's a good little case. The patient came in and I think he was 15 maybe when he came to my office. So clearly would have liked to have seen him earlier in life. His mom brought him in with a referral of a friend. The dentist had actually recommended doing a clear aligner therapy on him to alleviate the crossbite. And I don't know, many of you out there have tried to do much with expansion, particularly posterior expansion when it comes to Invisalign or Clear Correct or Sure Smile or any of the other aligner systems that are out there. Often those can become quite problematic, and most of the time what's occurring is really only dental tipping, and that's been backed up by quite a bit of research. When it comes to aligner therapy, you're really getting more tipping than really tooth control. But he shows up in my office, and I recommended that he needed expansion. Upon taking the CBCT, realized there wasn't a whole lot of cortical plate buccal of the molars and premolars, and at that point said, okay, this needs to be skeletal expansion in order to alleviate this crossbite that's present. So we placed 4 TADs and then used in a wholly TAD-borne or TAD-supported expander. You'll see some hybrid expanders out there which have both support on the TADs as well as they're supported by the bands around the teeth. Depending upon the case and the amount of cortical plate and how much expansion is needed, it will determine what type of expander I will use. But usually if I'm worried about pushing roots through the cortical plate and then setting the patient up for periodontal issues later in life, I prefer not to do that. And that's when I generally lead more toward skeletal expanders. And the research has shown that with skeletal expansion, you're getting, or skeletally born expanders, you're getting about 75% skeletal changes and about 25% dental tipping. With tooth-borne expanders, you're getting the opposite. You're getting about 75% of the changes occurring from dental tipping and only about 25% of the changes occurring from actual skeletal expansion. And that's even in young kids. So I'm really cognizant of putting expanders in children, particularly teenagers, without using some sort of hybrid or skeletal expander in those cases. And so you can see exactly how much expansion was done in the case. And this is his final photo. So not a bad occlusion. He's shifting a little bit in those buccal photos. He's not seated all the way down, but a pretty good result. Coincident midlines, nice arch forms, pretty happy with the result of the case. And here you can see before expansion how much cortical plate was present on the buccal of those molars. And you can see post-expansion how much cortical plate is present on the buccal of the molars. And even with skeletal expansion, once those brackets were engaged and the teeth were uprighted and the palatal cusp and treated to improve the curve of Wilson, you can see that even with that, there's movement of that buccal root toward that cortical plate. So I think had I used a traditional expander in his case, or just depended upon arch wire expansion in his case, I would have absolutely tipped the molar out and potentially pushed it out through the buccal plate and then setting him up for periodontal issues later in life. So really CBCT is incredibly helpful in these cases to determine what type of appliance is needed for the case. When it comes to procumbent incisors, this is one of the main reasons for Class 2 intervention or intervention in Class 2 cases with phase 1 therapy, and it's when the patient has procumbent maxillary incisors, and that's because of the increased risk for trauma. Sometimes that comes from lip biting or lip sucking. Other times it comes from digit sucking, tongue thrust or tongue swallow or tongue thrusting, mouth breathing, etc. And then we can see here, many times you'll take a picture of a patient intraoral frontal, and you'll just see the tongue just sitting there taking up all that space. And then you listen to the patient talk and you quickly realize, oh, we've got a tongue issue here like none other. And tongue issues are really, can be very difficult to deal with. And like many of the other issues we've discussed already, the younger the patient is when you begin dealing with the issue, usually the easier it is to correct and the more longevity and stability you have with the correction. So if you've got patients with tongue thrusts, many times appliances are needed. The appliance that you see there is a bluegrass roller. A lot of times I'll use tongue spurs, tongue cribs for those cases. In that case, it was a bluegrass roller. And then oftentimes, if you can just correct the habit that's present, you can get a pretty significant amount of correction as a result. And so this was before the thumb habit was corrected, and then the patient closed down quite a bit once we ended that thumb habit. And then you can actually see some attachments on the teeth there, and I finished this case out in aligners to get things where they are. Deep bite cases are difficult as well. Oftentimes we'll try to open the bite up with various treatment mechanics, and what we will find is that once we've finished treatment, the patient has a tendency to close back down a little bit. Rarely do they close back down as deep as they were before starting treatment, but just like open bite cases have a tendency to relapse, deep bite cases also have a tendency to relapse. So it's always a good idea in vertical cases to really do a little bit of overcorrection, knowing that you're going to have a little bit of relapse as things move forward. And then ankylosed teeth. This is another area that I didn't really notice a large problem with when I was in dental school at Louisville. I spent some time in Memphis. It really wasn't an issue in Memphis. When I did my residency at NYU, it really wasn't that big of an issue. But in Middle Tennessee, Nashville in particular, there seems to be a big problem with ankylosed primary teeth, and just the patients that, for whatever reason, they just are not exfoliating their primary teeth. So many times in these cases, you'll have to explain to parents that we'll need to extract the primaries in order to facilitate the eruption of the permanent teeth. Other times we'll actually want to use the ankylosed primary teeth, particularly if it's like a class 3 case, and we've got ankylosed teeth, and we can use those as anchorage to run class 3 elastics off of, and maybe even avoid face mask altogether. Sometimes patients prefer that to the face mask, particularly if they've got ankylosis and we're able to take advantage of that. Crowding, you always want to know the etiology of the crowding, and the earlier you can start monitoring the case, the better you're able to get an idea of what the cause is. Sometimes it's early loss of primary teeth. Sometimes it's decay. Sometimes it's just the patient's genetics or tooth size problems. But there are definite benefits to early treatment when it comes to crowding because we're able to gain some arch perimeter with some expansion if we get in there quickly enough. And then the problems that result from crowding is that many times you end up with teeth that are blocked out. So canines that are completely blocked out by a lateral and a premolar, and then you're having to make space. And if you'd caught the case maybe a little bit sooner, you'd be able to do so perhaps a little bit better. A lot of times we will see the crowding show up if it's in the anterior with blocked out canines or severely rotated incisors. Other times we'll see posterior crowding actually occur where the second molars are being blocked by the first molars, because there's actually posterior crowding that has occurred. And the benefits of early treatment when we can develop the arch form and get some additional arch length is, again, it reduces the likelihood of those teeth being impacted. And if we do need to intervene by extracting some primary teeth to facilitate the eruption of permanent teeth, we're able to do so in a manner and then maintain arch length while we do. So another arch length issue relates to spacing. Many times in these spacing cases, it's really a soft tissue equilibrium issue where the tongue is a lot of times larger than normal. And it's very difficult in these cases to recommend to the patient that they go and have the tongue reduction surgery. I know that I wouldn't want to have that surgery. It makes it hard for me to recommend that to patients. So often it's just a matter of informed consent that, hey, your child or you have a lot of spacing. Most likely this is a result of tongue posture or tongue size. And then we just tried to close, when we close the space, we tried to close it from posterior to anterior to not infringe upon the tongue space. And then again, we just let the patient know that the relapse is a big concern in these types of cases. Congenitally missing teeth, the sooner that we're able to pick up on problems with missing teeth, the better that we're able to begin the educational process with the parents and discuss treatment alternatives with the referring dentist, whether it's the general dentist or the pediatric dentist, and if necessary, potentially even get a prosthodontist involved. But these cases can be quite complex and quite difficult to treat. Implants have made things somewhat easier, but the problem with implants in cases that are presenting early with missing teeth, one is if you place the implant, the earliest you're going to place it is 18? Well, if the patient's 18 years old, they're still actively growing. Maybe they're not growing fast, but they're still growing. We still have growth throughout our entire lives. I got an implant placed when I think I was 35 or 36. And currently, I'm now 43. Currently, now I have about 1 millimeter incisal discrepancy between the upper right central, which is the implant, and the upper left central, which is my natural tooth. And it's because my maxilla has continued to grow and the implant has maintained its position. And so we end up with incisal edge issues or occlusal issues if we're placing implants when the patient's too young. So if we can do things that facilitate basically making space and then fill that space with some sort of prosthesis in the meantime till they're a little bit older, generally speaking, that's more ideal in my mind, just based on my own personal experience. All right, here's another case that we can take a look at. And I would have loved to have gotten this patient in sooner. I could have potentially done some sort of expander on them. I could have potentially had premolars extracted to facilitate eruption of canines. I could potentially have extracted primary canines and primary first molars on the maxillary arch to facilitate eruption of the premolars and then the canines. But I could have done a lot of things that I didn't get to do. And what ultimately ended up happening, and you can see here just how much resorption had occurred on the root of the lateral incisor by the canine. And so it was quite damaging to see the damage that occurred by the canine to the lateral incisor root on both sides. And here's the patient when I actually placed a TAD, extracted the lateral incisors, and exposed the the canine with a plan for canine substitution, but you can see just how much root was resorbed and the divot that was resorbed by the dental follicle of the erupting canine in this case. And I really feel like had I gotten the case earlier and seen this process beginning, then I could have potentially saved those lateral incisors and avoided canine substitution. And I think she ended up with a pretty decent result. Here's her final photos. Occlusion is not bad. But you know, most dentists, most orthodontists can tell a canine substitution case. Now, the general public, they have a hard time telling. So I don't think, you know, her friends certainly aren't noticing. Her mom is ecstatic with the result. But I'm looking at it and saying, I wish I'd have placed the bracket a little bit more gingivally, extruded those canines a little bit so that the gingival architecture would have been a little nicer. Inform them that, you know, one day they may need some veneers in this case. But overall, you know, the patient's happy. She's got a pretty good smile, so happy with her result. Here's another case. I actually presented this case recently to the residents at UT's University of Tennessee and Memphis's ortho program. And when I asked them, it was much more of an interactive format, much smaller group. But we had an opportunity to actually discuss some of the cases that I'm showing you. And the question was, do you see anything abnormal in this pan? And one of the residents pointed out, well, I think I see something maybe there in the maxillary left sinus. But other than that, everything is pretty normal. And I think that's actually a ghost image from the earring that should have been removed when the pan was taken. So here is the rendered ceph on this patient from the 3D volume. Very little that's going on there, nothing that would just make me say, oh my gosh, there's something wrong here. But then when you look at the coronal, the sagittal, and the axial views on this case, you notice that there's not just one supernumerary tooth, but there's actually a couple supernumerary teeth. And perhaps if we'd picked up on this sooner, we could have had those teeth extracted earlier for the patient. And here they are. And imagine if I had tried to upright the roots of those central incisors and wondered why aren't these moving, or potentially actually caused damage to those roots as a result of trying to move them into other tooth structure. That certainly wouldn't have been ideal. So I feel like 3D technology and CBCT gives me much more information than I would have had with just 2D radiography. Not only do I have more information, but I've certainly gotten this information at a significant reduction in radiation. So in my mind, it really becomes a no-brainer. So in review, what have we discussed today? We've looked at some transverse problems, some anterior cross bites, open bites, habits, talked about ectopic eruption, class 2 and 3 cases, discussed premature loss of deciduous teeth, moderate to severe crowding, spacing, deep overbites, severe overjets, and discussed dental trauma. For those of you that would like some more information, you can talk to your friendly neighborhood orthodontist, and the AAO actually puts out quite a few brochures on with some flyers about when to refer, what to watch for, not only in early treatment cases, but also in adults and when to refer those. Another great book is Prophet's book, Contemporary Orthodontics. And then if you're looking at CBCT, particularly as it relates to orthodontics, Sunil Kapila's book is excellent. And with that, I will take some questions. So let's see here. So one of the questions is, do you have to take a separate ceph with your 3D scans for ortho treatment? Many of the manufacturers of CBCT machines, Planmeca included, will sell you a ceph arm to add to your machine. I had the option to purchase that. I did not. Anytime I need a ceph, I just generate it from the full volume that I took on the patient. So I really don't, I don't have a need for a separate Ceph arm. And then another question was, what about radiation in young kids that are basically growing? We're going to have to take radiographs along the way to evaluate eruption, exfoliation, whether or not there's missing teeth there, whether or not there's supernumerary teeth there. So radiation is going to occur when we're talking about treating. What makes me feel better or lets me sleep better at night is knowing that the radiation dose that I'm using is significantly less than the radiation dose associated with 2D. So when it comes to not only am I using less radiation, but I've got more information to diagnose and treatment plan the case with. So I would say the advantages of CBCT as it compares to regular x-rays from an orthodontic perspective is huge, both from a radiation dose perspective and the amount of information that we have with which to diagnose and treatment plan the case. How often during treatment do you image? For early treatment cases, I'll usually take CBCT. Many times it'll even be a limited field of view or a dental only CBCT if I'm not worried about skeletal issues in a young patient. But most of the time it's initial records and final records for phase 1 or early treatment cases. For phase 2 cases, it's usually 3 treatment points, initial records, progress records, and then final records. And then the question is, do you have to send out your CBCTs to have them read by a radiologist? I would say that depends upon where you practice. Currently in the state of Tennessee, you don't have to do that. Honestly, by the time you've looked at the number of images that most orthodontists will look at over the course of 3 or 4 or 5 years with reports associated with that early on, you kind of get a good idea of what you need to refer out for with regard to having a radiologist look at, or whether you feel comfortable signing off on it yourself. No radiologist would love us to send out every one. I don't think that's necessarily needed. But there are certainly some orthodontists out there that do just that. I got a good friend in Knoxville, Tennessee, and every single CBCT, he only takes CBCTs on his patient, and every single CBCT he takes is read by a radiologist. So I just really think it depends upon how much experience you have with the technology, how much experience you have in radiography, and then basically where your comfort level is. I had a question about ALATA versus ALARA. I think on one of the slides it said ALATA, which is as low as diagnostically achievable. In the past, when we were looking at 2D or just radiology in general, we were talking about the ALARA principle. There was a time where we thought that things might move towards the ALATA principle, basically as low as diagnostically achievable, meaning we're going to use whatever radiation we need to get a diagnostically beneficial image for the purposes that we're taking it. And so it basically takes ALARA one step further and says, with the ability to resize the volume, the ability to do ultra low dose imaging, the ability to change the resolution of the volume, to change the KVP and the MAs, it gives you quite a bit of control over what the results of that CBCT volume will look like. And as a result, depending upon the need of the volume will determine the resolution, whether it's ultra low dose, the size of the volume, etc. That was a good question. Could you please comment on insurance coverage over CBCT? I'm guessing this involves malpractice insurance. The truth is, when it comes to liability for diagnostic imaging, in my mind, you're responsible whether you take the image or not. And what I liken it to is, imagine the orthopedic surgeon that decided to operate, that had a CAT scan available to him, but only said, I only need 2D imaging. even though CT was available and insurance was willing to pay for it, then he gets into the case and realizes, oh man, I really needed CT on this case because I basically missed something. And had they taken the CT, which they had access to, the case could have been treated better. So it's really not a matter of are you liable or not liable. It could easily be said that if the general dentist has a CBCT machine down the road and you only took a 2D radiograph and you missed something that you would have caught in 3D or that a radiologist would have picked up on in 3D, but you didn't because you only took 2D, then I would say you're just as liable as the doctor that they're the orthopedic surgeon that only took 2D. So I think it's the liability issues. You're liable for what's going on with the patient while you're treating them anyway. I feel much better knowing that I've got more diagnostic information to work with as opposed to less. How do you present TADS as it is a mini implant? It's just I call it a little mini pin when I'm talking to the patient. We're going to put it in your gums. We talk about that, you'll be numb, that I myself have had TADS, so I can explain my personal experience with them. And so it's really not an issue. The TADS usually end while you're using it for anchorage, and then once you're finished with it or finished with the case, you remove it, and there's very little sequela associated with it. Airway, I didn't get into today. Somebody had a great question about airway. In my practice, I will use the pediatric sleep questionnaire, particularly in patients. When I take a CBCT and I see a narrow airway, that's a trigger. If I've got the patient in the new patient room and they're bouncing off the walls and appear to have ADHD, that's a trigger. When I'm talking to the parent, if the patient is falling asleep in the middle of the exam because they're not sleeping well at night, that's a trigger. If they're obese, that's a trigger. And that will facilitate me asking about or giving them the pediatric sleep questionnaire. Just because they have a class 2 or a recessive mandible doesn't necessarily mean that they're going to have an airway problem. As airway not only is a result of the size of the box, but there's a lot of neuromuscular and other elements at play there. So it can be an indicator, but it certainly can't be diagnostic. Someone asked about the services of myofunctional therapists in these cases to have better retention. I'm assuming that they're probably referring to open bite cases, tongue thrust cases, non-nutritive sucking cases. And in my experience, I really don't have, there actually is a myofunctional therapist up the road, but I honestly, I just haven't. We weren't trained with it in residency. There's been more information in the last couple of winter meetings about myofunctional therapy, and I've been doing a little bit of research on my own, but I like to kind of know what I'm doing before I just jump in. So it's going to involve some CE for myself before I really start doing much with it. Somebody asked what a CR and CO stand for. Centric relation. So it's the jaw relationship with the condyle being seated in the most anterior superior position. CO is a tooth position, or maximum intercuspation, or MIP is another acronym for it. And then another question, how often do narrow palates lead to airway problems as adults? That's a great question. I don't know that there's been much research on it, honestly. If the airway restriction is occurring in the nasopharynx, I would say the narrow palate could potentially lead to airway problems. It really depends upon where the obstruction is, for it to be an issue. If the obstruction is in the nasopharynx, then potentially expansion could improve that. But in an adult, you're really looking at doing a surgically assisted expansion as opposed to just a TAD supported expander, just because most of the results with the TAD expanders have been mixed at least at this point in the literature. And it said, what brand of skeletal expander do you use? It's not a specific brand. I just have a lab fabricated. It's basically the Hyrax screw with the acrylic over it, and then you cure the acrylic on top of the TADs. It's a little bit of a pain to remove, but the other ones out there, I think the hybrid ones where you've got basically round loops that engage the TADs, but then you've also got bands on the molars. Those are pretty much both working on expanding dentally as well as just skeletally. And when I'm placing 4 TADs in somebody, I'm usually looking at trying to achieve skeletal expansion or trying to get a lot of expansion. So it's not a particular brand. The lab I use is Specialty Appliances. Before that, I used a local lab, but had great results with both. I would say you want to get clear acrylic instead of the pink acrylic, depending upon your light cure and whether you're using dual cure or light cure resin can make it maybe make a difference there. Let's see here. In regards to expansion, is it correct that dental tooth-borne expander in young kids is it supposed to work as efficient as TAD-borne anchored expander? As younger the patient, you'll get more skeletal results. Yeah, so in really young kids, I will sometimes use kind of a quad helix because the suture has not fused at all. They are extremely malleable, particularly if they've got plenty of buccal bone lateral to the molars. Then a quad helix is great, or a traditional Hyrax RPE is great. I really base it on not only the age of the patient, but looking at the suture development in the case, as well as the bone lateral to the upper molars, to determine what type of expander is necessary. So it's really not an age thing, and then that lets you make the decision. It's really a patient anatomy thing, and that's the other point that I'm glad you asked this question. Once you start using CBCT, you really stop looking so much at analyses and really start looking more at the individual patient's anatomy, because it is the individual patient that you're treating, not just to some historic norms based on racial type. So it really is much more individualized patient care. And then the last question, how often is it recommended to monitor versus extract ankylosed primary teeth? I've heard they oftentimes will eventually exfoliate on their own. Is there a time window to monitor? Usually I'm working through basically my decision point is once 2/3 of the permanent tooth has formed and we're 1 year past the normal eruption time, at that point is when I make the decision to extract the tooth. I will usually let it try to hang on and then maintain the vertical position of the opposing dentition with some sort of appliance so that you don't have super eruption of teeth. But in general, that's kind of my rule of thumb, 1 year past normal eruption time and 2/3 root formation for the time that we'll extract. What time is it? I got time for a couple more. Let's see here. Can wisdom teeth eruption cause misalignments and shift of the adjacent teeth? Every patient I talk to believes that this is true. Many dentists and pediatric dentists that I talk to believe that this is true. All of the research that I've ever seen done on wisdom teeth causing eruption says that it is not true. But you try to tell a patient that, and they will think you've lost your mind. So rather than try to beat my head against the wall, many times I just smile and nod because if that's what they think, that's fine. Maybe it'll encourage them to wear their retainers more if they still have their wisdom teeth present. If they don't have their wisdom teeth present, I just really try to reinforce, hey, you need to wear you need to wear those retainers to maintain the position of the teeth. And I think most orthodontists have gone to lifetime retention at this point, as most of the research supports that. Let's see here. What is the best age to refer to an orthodontist when a patient requires palatal expansion? You can't ever go wrong referring earlier as opposed to later. So I would say the sooner the better. Again, it gives them more treatment options. The bone is more malleable. The sutures are certainly more capable of being expanded. So the younger the patient, the better, generally speaking. Let's see. Be changes in CBCT or submeasures not registered correctly in the denture patient. I think only that applies today. If we know we continue to grow, then why can't we still expand in adults, the sutures? That's a good question. So the question is, if we know that we continue to grow, then why can't we still expand in adults? The sutures are still malleable, but just at a slower rate than in children. It's not that they are malleable, it's how interdigitated they are and how much bone is present in that interdigitation, both inferior superiorly as well as laterally, as those little tentacles interdigitate. So it's not that it can't be expanded. You can expand in adults with just skeletal expansion, but you've got to essentially break that suture. In some adults, that's easier said than done. The thicker the bone, the more dense the bone, the less suture material that's there. And in adults, there's very little actual suture material. It's really more that the bone has fused as those tentacles have interdigitated. So it's not that it can't be done, it's that it's more difficult to do. The rate of expansion really has little to do with it, as much as the amount of force that's needed to cause that suture to fracture, because that's basically what you're doing in a case like that. And then once it's fractured, then you've got distraction osteogenesis taking place, not so much sutural expansion. So from a growth and development standpoint, you're really looking at two different modalities, I believe. I would have to do some research on that, but based on my memory from growth and development and bone morphology, that's kind of where things are. And then also based on the research that's been done on the various expanders that are TAD supported out there and their use in adults. Again, the results of that have been very mixed. Some of it depends upon where it's placed. It depends upon patient selection. There's so many variables that go into it that many times in adult patients, it's not that the suture can't be separated. It's that the amount of force that it would require. Many times the appliances can't withstand that much force. All right, I think that is great for today. Thank you so much for your time. I really enjoyed hanging out with everybody. Great questions, and hope everybody got all the information they needed. If you need to find me or have other questions, don't hesitate to shoot me an email. My email address is burton@smilemaker.com. So just my last name @smilemaker.com. So I'd love to answer any other questions that you have. Other than that, y'all have a great night and hang in there.